can hear you.
Okay, let's start
Oh,
the Saturday conference today.
okay, can you see my screen right now?
Yes, today Dr. Han in Cambodia will present interesting EKG. Dr. please.
Okay, thank you so much, Professor Park. Good morning, all the professor and all the doctor. It's also good morning, Dr. Huang. So today, it's my pleasure to share an interesting ECG with you. So wait, this is the ECG.
화면 공유를 좀 해줄래요? Screen share.
And can you see my screen?
Yeah, but it is not the slideshow format. It is original PowerPoint. Can you blow up the screen?
Your screen.
Slideshow, please.
Okay.
Yeah. Okay. So heart rate 207. And there are alternately two different kind of thoracic morphology. So who will start first? 김준태 선생님. 거기부터 시킬지 몰랐죠.
P웨이브 몰폴로지가 두 번 조금 델타 웨이브처럼 보이는 QRS 앞에는 P웨이브가 명확하게 보이는데 그 조금 더 내로우해 보이는 QRS에서는 P웨이브가 명확하게는 잘 안 보이는 상태인 것 같습니다. 그 다음에 교수님께서 언급해 주셨듯이 얼터네이팅하는 QRS 몰폴로지로 보이고 있고 는 둘 다 동일하게
네.
예.
황태 선생님. 앞에 읽으시오.
WW 벡터가 있는데 이전이 책을 보는 건지 아니면 APC가 그런 나오는 건지
크게 돼요. 크게 얘기해주세요. 어?
WPW도 테스트가 있는데 이제 APC에서 책을 보는 합의하는 게 어려워. 추가적인 접시로 렌즈를 해봐야 되죠.
Okay, Dr. N, did you try adenosine for this patient?
Yeah, I did try adenosine on these patients, and this is during 10 milligram adenosines.
Okay.
And when we start adenosine, the heart rate is start to go higher and higher until this one.
Okay,
So
hang on.
this is
Hold on.
yeah.
Go back to the ECG first.
Oh, Dr. Wang, morning.
Good morning. How are you? It's a good afternoon here. So let's look at the ECG first. EKG before, first ECG.
Yeah,
Okay.
this one is first ECG.
So one of our fellows suggests that this is tachycardia with intermittent pre-excitation. Is that one of the differential diagnosis? Anything else? Any other different potential diagnosis? First of all, do you see a consistent correlation between whichever you call P wave, and the QRS? Yes or no?
No, yeah, I mean, there's p-value, but the p-value is not correlated with the QRS.
Okay, so that would be one differential diagnosis, right, Todd?
Yeah,
Okay, so then what would be? Patient had one rate of whatever sinus or atrial activity, and then another rate of a ventricular activity, right?
yeah.
So
So
what you said is what? Is it potentially could it be a VT? You said just dissociated.
I don't think it is dissociated.
You don't think it is associated. What is
Because
what
it's
is
a little wider QRS, in front of little wider QRS, there's regular P wave.
So how do you explain that QRS is alternating? Is it rate dependent? No, its rate is not that fast. Okay, 200 beat per minute. Or what?
Two different pathways to ventricular activation. One is
Okay.
current, the other
So
one
one pre-excitation, one is a sinus rhythm. What you're saying? Or two different pathway?
yeah, one possibility is the accessory pathway conduction and the AV nodal conduction alternating. And
Okay.
the other one is another is the paratician ventricular vision. But I think the RR interval is quite regular and fixed. So I prefer the first hypothesis.
Okay. So if this is a pathway, okay, where's the pathway? Can you tell me where the pathway located?
Where's pathway?
You got the 12 lead, so you should be able to tell where the pathway is if this is a pathway. Is it this pre-excitation pattern match any kind of pathway you know? That's what I'm asking. Is there any suggestion anywhere? You could argue could it be left-sided pathway, but then B1, B2, B3 is negative. So very unlikely, right? Because the pre-excitation has a certain patterns that we know. If you have a positive 2, 3 in AVF delta, and then maybe AVL you suggest a negative, then it's got to be left side. Can be right, right? Yet, precordial lead does not support that.
yeah,
So how do we reconcile this? So we need to discuss these issues because this is part of your training. We may not be able to give you right diagnosis, but you need to start thinking. That's what we want you to do, okay? If it is a pathway, then what? Where is this pathway? Is it match, mismatch, so on, okay? So other possibility, Dr. Park's suggestion may be, ventricular level, some sort of intervental conduction aberrancy, some differences can happen. Or there is a summation going on between the P and the QRS, maybe changing the morphology. Because if you look at the, certain leads only that happen, other lead does not. But there's one thing against the, I would say, summation issue. If you look at the ventricular lead, V4, V5, V6, take a look at it. Can you see P wave there? You cannot tell the P wave, right? Almost. There is at the front, right? So
yeah,
when
like
you're
a
narrow, yes, when you're shorter, if you will, you have a P wave preceding, right?
yeah,
But when you're tall, there's no P wave, correct? Agree?
yeah, yeah,
Okay,
yeah, I agree.
that's just what? Is there artificial summation going on? Two wave front, is a positive and negative, interacting each other, giving you taller than other? Is it possible? Another mechanism is alternance, right? But again, rate is a 207. I do not know what's the hemodynamic status of this patient. Certainly could have an alternance. And there's another possibility I would need you to think about it. What is that? If you have a large pericardial effusion, patient heart can swing back and forward. Even though your lead is in the same spot, your axis can change, simulating alternance. We call pseudo alternance in patient with pericardial effusion, tachycardia. Make sense?
Yeah,
Okay.
but we did check echo at that time.
I know
and
that.
it's no
I know you
issue.
did, but I'm just giving you differential diagnosis, my friend. That comes later. Okay.
Okay.
So those are things that we can think in this EKG. Okay.
Okay.
Any other possible explanation, gentlemen?
I still prefer the potential pre-citation.
Okay. Yes.
The
Everybody entitled to that.
recovery is exactly same.
Uh-huh.
As you told, the localization is not perfect, but the pre-excitation is a fusion bit of normal conduction and accessory pathway. So if this minimal pre-excitation is hard to localize the accessory pathway location. And another possibility is if the patient has multiple accessory pathway, it could change the QRS of the morphology.
Okay, Dr. Bach, let me ask you this question then. Your hypothesis is correct. If you look at the precordial lead, they just pointed out that the shortest PR interval is in the short, not the tall one, short one. Am I right? Is that more pre-excited?
Which
Why
one?
is it more pre-excited?
Which lead are you talking about? Lead 2?
Yeah, lead 2. P is right, it's just right on top of it. So that would not be more pre-excited? Your conduction time is shorter there.
Yeah, too short.
Yeah, and then the taller one is a longer PR interval.
Right.
So how do we explain that? So there's a certain feature that we look at it. You try to make a reasonable argument, evidence-based. So you need to ask all these questions I'm asking now because I want you guys to start thinking all this, okay? So there's all possibility. I think it all could be reasonable, but then we need to sort out one by one. Okay, then what happened? You ask, Dr. Bach asked adenosine. Hang, show the adenosine.
Yeah.
Okay.
Response.
Okay, now what happened? Adenosine, basically, if they blocked, would block what? AV node,
Block
right?
that. Maybe not, yeah.
Right. Now, do you see distinctive P wave here? Yes, you do, right?
Yeah, in front of every
Yeah,
QS.
PR interval is a steady regular, and QRS now the shorter, all of them, right?
Yeah.
Okay, so based on this, can you make a diagnosis whether this pathway is?
Yeah. No.
No.
If it is a pathway, then V1 negative should be on the right side or at the septum.
Okay. So this is adenosine is given, how much? 10 milligram, okay?
10 milligram.
And heart rate went up, right?
Yeah, it's go up to 240.
Because of what? Adenosine did what?
It's blocked in the AV node, and I don't know why the conduction is going faster and faster.
Oh, adenosine also has what? Vasodilatory mechanism. Remember?
Oh, yeah.
Yeah. So when blood pressure drop, then your heart rate would go faster, right? Now let's look at this. Assume this is a pre-excitation. Let's assume, okay? Is the pre-excitation got worse with a faster rate? Go back to the previous ECG.
Yeah, more augmented.
Go back. Yeah, there you go. So your QRS width, okay? I want you to look carefully now. In the lead 2, I guess. That's the first facing the lead 2. Is it correct?
Yeah. Yes, it
And then you follow that carefully. And then where that line drift after your chart. Follow that line. Keep coming. Keep coming. Keep coming. Keep coming. Keep coming. Now start watching. What happened with the delta? Whatever you're calling delta. Getting broader, wider. Do you see it?
Yes.
And then that keep coming. And then coming down, get narrow again. Keep coming. Now you see it? Hang.
Yeah.
Clearly different, right? Nothing.
Yeah.
So that supportive of Dr. Park's idea that this could be pre-excitation because of your blocking AV node facilitating, the your mechanism. Now, question though, what is the mechanism of tachycardia driving this thing? Now we need to start thinking. If it's an AVRT, okay, you block the pathway of AV node, well, just to terminate, right?
Yeah, it should happen.
Right? Didn't. What happened next? Got faster. Go to the next case, next ECG. I know you sent me this tracing to look at it. I didn't have time to reply because I just came back from somewhere else. Okay. So your heart rate went 244, accelerated. I assume because adenosine dropped the blood pressure and then catecholamine surge, all this happening. And tachycardia went faster and it gets steady wider. So then what's the differential diagnosis here now? Pre-excitation, possible. But what's the driving tachycardia? That's more important for this patient, right?
Yeah.
Yeah, in not atrial fibrillation, because it did not go irregular. What other different
AT.
AT? What else?
Oh,
Maybe two different top pathway? Possible, right?
So,
One orthodromic, one antidromic tachycardia, two pathway. Even you block AV node, you're gonna keep going, right?
mm, yeah.
Yeah. What else? Tachycardia. Okay. Driving this pathway, right? Which are not sensitive to adenosine. Anything else? Because you have a correlation to P to whatever this wide complex tachycardia. That's what you just told me. You see every front of that, there's a P wave. Is that true? What are you telling me? I want you to look carefully. Yes, that one. Go to the next one. You don't have that much. Another one, there's a hump. Right before the QRS complex, certain things have a bigger hump than other. See, that hump has a pattern. Did you measure those guys? Why I'm asking this question? Because one differential diagnosis we were raising was this could be possibly also some sort of a dissociated VT pattern.
Yeah.
So then you need to look for those things. So in other words, what I'm trying to induce to you guys, if you made a list of differential diagnosis, you want to keep searching for every single differential diagnosis and every tracing, you answer yes or no. That's how you eliminate your possibilities. Evidence-based. So I want you to keep tracing. I want you to look at the lead two, go to top, hang, go to the hang, lead two, tracing, keep coming back slowly, keep coming, keep coming, keep coming. Next one, no, just passed, just go back there. No, go back, one more. Right there before after the QRS complex, that S segment has some notching, is a little bit taller. And then other ones goes down. You keep following that S segment, see what should happen. Keep going. So concern that we are raising here is that is S segment where the absolute repolarization happening, unless it's a secondary wavefront is present there, you shouldn't be deformed that. And you keep coming back, and then there's a certain QRS complex followed by a taller P, looks like a structure. Next one, that next bit right there, you just passed. You see that? That's a little different. Once in a while, I see that. So I don't think we can exclude still possibility of a VT here. You cannot exclude this. Okay. And second, patient heart rate went faster. So if ABRT, you give a 10 milligram, I think it blocked the AV node, then should terminate. Didn't. So possibility left is what? If there's a pathway, probably automaticity, some sort of adenosine resistive supraventricular rhythm driving ventricle. That's one. 244. I don't think it's fast enough to be flutter. But could it be a tachycardia? Yes. And other different diagnosis what? Two pathway, one orthodromic, one syndromic tachycardia. And third would be still maybe upper subtle VT, some sort of a tachycardia causing this. Okay. Any other suggestion, gentlemen, so far? So we have eliminated one tachycardia so far.
So based on this ECG during tachycardia, can it be an AT and it go to the two different slow and fast pathway?
Slow, fast,
So
epidemic. AV node reentry, that's what you're talking?
no, I mean it's AT, but the conductions is going to the slow and the fast pathway at the same time.
AV node? Even dual AV node or conduction you're talking? Or
Yeah, I mean dual AV node conductions with
no,
AT.
you could not explain why the QRS are changing. Because if you have an AVNRT, dual AV node or conduction, your conduction has to go through no matter what his bundle, correct?
Yeah.
The QRS has to be the same unless there's a alternance going on, aberrancy, every other bit. But there is no pattern of aberrancy here. Do you?
Yeah.
Make sense?
Okay.
AVNRT does not require ventricle or atrium. Therefore, lower common activation pathway is gotta go to the his bundle. Whether slow, fast, slow, fast, slow, whatever. So your QRS always used to be the same, unless there's a second altering factors, such as metabolic disease, some hormones, medication, so for causing aberrancy. But then EKG patterns should suggest aberrancy. And I don't see that.
Because the tachycardia didn't respond to adenosine and two different QRS morphology alternating with exact same RR interval. So bottom line is this tachycardia doesn't, at least two different pathway. And for the maintaining the tachycardia at adenosine, AV node it's not involved in the reentrant circuit.
Correct.
So adenosine is a blood dropping action, but also the adenosine sensitive potassium channel, shorten the action potential duration and accelerate the potentially ectopic tachycardia. So how do you think the ectopic tachycardia driving with multiple accessory pathway or the alternate induction?
Most likely what you're telling us is correct, because of a patient has a bystander accessory pathway, and then you have a intermittent every other bit of alternate excitation due to the rate. And that actually the pre-excited complex is not the tall QRS complex, it's a narrow QRS complex. That's the first point, okay? Second is that when you give adenosine, QRS amplitudes all became same and short one, and the AV node block caused that, so they got rid of one of the AV node conduction or fusion, whichever you call it. So I think a patient has clearly some sort of adenosine refractory automatic tachycardia or some sort of reentrant tachycardia in atrium. I cannot tell you whether it's a reentry or atrial tachycardia, most likely, and have probably the bystander pre-excitation. The question I have though, finally, Dr. Park, where is this pathway, if there's a pathway, can cause this?
And also how to tell. And also there's a lead to the short amplitude QRS preceded by P wave, but the P wave is too short to be conducted. So I cannot explain that phenomenon yet.
So based on the lack of a pre-excitation pattern, almost normal sinus rhythm pattern pre-excitation, when do you see that? Do you see that in fascicular ventricular pre-excitation?
Could be.
Could it be? Yes. Because of a fascicular ventricular pre-excitation would not have a mechanism of tachycardia per se,
Yes.
but that would give you a different pattern of EKG, right?
Yes.
Yes. Okay. Anybody else? Any other argument? Any concern? Questions, please.
김대원생, 김대원생,
Okay.
검대원생.
Okay. So what did you do, Hang?
Actually, I give two
What?
time adenosine,
Uh-huh.
10 milligram each time, and it's the same response like this one. It's
Sure.
going up around
Okay.
10 to 20
Mhm.
milliseconds. Then it's go back to this ECG.
Okay.
No response, no AV block at all.
Mm-hmm.
And then after 2 times of adenosines, BP's was dropping at that time. So I explained the patient and we did the cardioversions, synchronized cardioversions, but we couldn't record it because it's just a monitoring, not a telemetry. So we don't have that ECG. But after cardioversions, it's not respond. Three
Okay.
times, 100, 150, and 200, still no response. And the tachycardia is still going on.
Okay. And so what happened? Tachycardia keep going. So the patient life still?
Yeah. And
So what
so
other, hang on a second. What other drug you could try to hear that could help you differentiate these two? Adenosine is the most commonly used drug.
yeah.
And you notice that adenosine causes a blood pressure drop and a fast increase of tachycardia rate, but it doesn't help you. Okay? So would you consider to be giving some calcium channel block to this patient?
I think about that also. We have verapamil injections in our center, but my hypothesis first, I think there has an accessory pathway, so that's why adenosine block the AV node and the conduction is going through the accessory pathway. So I'm afraid that if I give a verapamil with a long actions, it's block AV node and the heart rate is going faster and faster, and I cannot control it, and the patient may be dangerous. So didn't give
other
that.
interest that we want to know whether calcium channel blocker, you proven adenosine that is not actually pathway conduct using AV node already. So next step is that whether can we try to sort of slow down focal tachycardia, sometimes atrial tachycardia, some other mechanism responsive, they responded to the calcium channel blocker. So verapamil 2.5 milligram, small dosage. Or you can do matter of the fact that you could use also beta blocker IV intravenous if you had one. Two, then you have a further proof that the two things. One, QRS width widening further out with the verapamil, yes or no? Why I'm asking that question? Because if you look at with your earlier discussion that QRS complex dissipation pre-excitation did not match any AV group axillary pathway.
Yeah.
Okay? So then what you left? Septal origin, most likely what? Fascicular ventricular, any bystander pathway behaving like a true pathway. So if you start thinking that possibility, maybe verapamil have a longer effect of slowing tachycardia, hemodynamically stable. So adenosine is a very useful drug, but if you misdiagnose atrial flutter, you give adenosine, patient go to really fast one-to-one atrial flutter. After that, adenosine effect disappear because they get hypotension and catechol surge. It's actually in many cases published the earlier days of adenosine trial we used to do in US. So next time, if you have this question, Todd, what you haven't given me an answer yet. What would you do first? Carotid massage is very cheap, useful thing to do, especially left side one, because that will create more AV block. So carotid massage, right side, more sinus node, left side, more AV node. Remember that? Next time. It's very simple, cheap, doesn't cost too much money. You just hook up the telemetry, watch what happened with the patient. Okay?
I think Dr. Taeong Kim has something to tell.
Okay, tell me what did you got? So, do you shock the patient? Not successful.
Yeah,
We
sometimes not successful.
Then what did you do?
I give amiodarone.
Amiodarone. Okay, so the amiodarone, what happened? You have a tracing, I
Still
assume.
the same, cannot terminate tachycardia, but it just slowed down a little bit.
Okay.
But we didn't record that
Huh?
ECG. We couldn't record it. It's just on the monitoring.
You could not record the monitoring
But
ECG?
yeah, in the monitoring, it's still the same pattern. It
Okay.
just go down to 180 and then sometime 180 and then go
Fluctuation.
to
Okay.
200 again, up and down like that.
Okay, so gradually terminate. What you say?
No. It didn't terminate the tachycardia.
So then what happened?
So after that, in the morning,
Uh-huh.
our senior come and then he stopped the amiodarone and give adenosine one more time, 20 milligram, and it terminated tachycardia.
Okay. So,
And this is the sinus ECG.
okay. So what does the EKG shows? Is a similar pattern of the what we seen? Well, no, go to the your first ECG. Is the axis are completely different, right?
Yeah, axis is different. And
Mhm.
in tachycardia, 2, 3, and ABS, both
Positive.
is
This is
have.
negative. So what would you discuss here? Differential diagnosis now. Based on this, let's finish this up. What kind of tachycardia can do this? You still think it has a pre-excitation?
No, because on 12 ECG, we don't see any anterograde conduction of the accessory pathway.
Okay. And the QRS complex that you showed to me is originated from where? VT. If it was VT, where's it originating? This patient heart is looks like a more, leftward axis, but the your lead one, all that is a positive, but the transition is all same. Patient just had a QRS widening and narrowing, similar to the except the 2,3 AVF was positive, right? So what do you think that this patient had then? Since you saw your patient. First question, is it VT or SVT, you think?
I don't know how to answer that question.
You don't know how
But,
to answer the question.
but
Okay.
in the morning, during adenosine,
Uh-huh.
in the monitoring, I can see an AV block,
Yes.
a long AV block with 1 or 2 with V escape rhythm, and then it's go directly to sinus rhythm. It look like more SVT, but the response of adenosine is different from what I did at the night time. I
So
don't
you
know
think it,
because of the amiodarone, it
Mhm.
changed the tachycardia or not.
Well, the amiodarone stopped how long ago? Right after the amiodarone stopping, or is long after the amiodarone discontinuation give adenosine? Doesn't make a big difference. He stopped the amiodarone, just gave adenosine, I assume.
Yeah, just stop and give adenosine.
Okay. So basically, you have to say that the patient had amiodarone and adenosine on board.
Yeah.
Okay. And the looking at the your tracings and all that, certainly amiodarone effect that you cannot provoke any more pre-excitation is possible too. But I think if you had a chance to slow down the tachycardia gradually, there would be a probably better approach to mechanism diagnosis. Adenosine, you hyperpolarize also your focus. Remember the mechanism of adenosine?
Mm.
Why you give adenosine after pulmonary vein isolation? You hyperpolarize the remaining injured cell, therefore you enhance your conduction, action potential. And the mechanism of adenosine A is a little bit different than that. So I don't know whether we can conclude this is truly SPT or some sort of atrial tachycardia or some sort of a high septal origin VT. It's very hard to know at this point. So very interesting mechanism of tachycardia anyway. So you need to start probably thinking about this a little bit more. I will take a look at the tracing a little bit more, then let me, I thought that you sent me on 2 ECG. Am I right? EKG of adenosine and tachycardia, right?
Yeah, all the ECG except the sinus rhythm one. I didn't
Okay.
send you.
Can you send me again those? Let me take a look at it. If I have a different idea,
Okay.
I'll let you know.
I will send you this slide presentation
Okay,
to you.
good. All right. I appreciate that.
Actually, our senior did an ablation to this patient, and I also recorded. I assist only also in this case, and I did record some intracardiac signal also.
Oh, good.
So the tachycardia was in use at the board extra 500, 260, from 300 to 250. It's in use around that. And this is the tracing.
Okay.
And catheter position. He puts only one decoupler on the RA and one decoupler in the CS.
So
Early signal were found as it's 910 and around CS os area. But ECG, I don't think it's look the same as the clinical ECG one.
right. But still your PR interval, all that is similar to that in a tall one, right?
Yeah, to the tall one, not the short
Yeah,
one.
to the tall one, not the short one. Okay. So did they able to entrain or do any of those maneuver here?
No,
No?
that unfortunately.
What did you do? He just burned it?
Yeah. So
Burn the CS off?
썸을 탔구나, 부담.
Huh?
So this is the signal before ablations. We didn't do the maneuver. So it just burned at the CS
So
floor,
you
roof
don't,
of the CS os.
so you don't know whether this is a focal tachycardia or reentrant tachycardia. But an induction method looks like a reentrant tachycardia
Yeah,
because you got S1, S2, S3, right?
yeah.
Okay. There was any jump, anything like that?
We don't have the his catheter also.
Huh?
This is catheter positions.
No, but measuring just your eyeball in the interval that you should be able to tell though, right? Whether induction, let me show that induction there you had that one tracing there you had induction.
Yeah. Single
You
could
don't have
not
extra
induce the
stimulus here.
tachycardia.
Yeah, you don't have
Yeah,
extra stimulus. Maybe you can, do you have a tracing still at computer? You think?
yeah,
So
yeah.
why don't you go print out some of the tracings for us? Let's take a look
Okay,
at it.
I will check again.
Yeah, and then we can discuss again, see what's the mechanism of tachycardia. Maybe the fellows can learn something here. Okay?
But we didn't do much maneuver
I
during
know,
the.
but you can do pacing, tracing of 500, 260, 300, 350.
Okay.
So how the induction of tachycardia initiate. That would also give us a clue. Okay?
Okay.
Hi, who was the operator?
It's our senior. I just assist the case.
Okay.
Our senior, you mean Chandara?
Yes.
Okay. I would not expect anything else, but that's fine. But you know, the question that you remain that you got long RP tachycardia with the inverted 2-3 in AVF. Question is a focal tachycardia or it is AVNRT bystander. But based on the what we learned so far, unlike AVNRT, because of you gave adenosine and all that, and tachycardia accelerated. So question is automatic focal tachycardia from the coronary sinus os causing this type of behavior? Is it possible? But if you look at your EKG, EGM that as far as I can tell you, look at your catheter position. So, you know, 1, 2, 3, 4, 5, 6. Look at the floral picture quickly. Let's take a look. And then you show us a floral picture. So it's basically you're inside the CS. This is LAOB, am I right?
Yeah.
Yeah. Your same level of the coronary sinus catheter. Coronary catheter is inside the CS, all of them. So this is could it be a roof CS tachycardia, or could it be you know, focal tachycardia from left atrium as well? You cannot exclude that possibility because you don't have a his bundle catheter and you don't have any other catheter. And go back to the tracing again. And also, if you look at your HRA signal 910, can you see that?
Yeah.
So next time I need you to measure from the CS to the 910 signal, okay? So that difference eyeballing looks like a more than, you know, 40 milliseconds, at least to 30. So it's assuming that, you know, all inside the CS may not be, you know, acceptable idea. You guys should have mapped the roof of left atrium as well. I mean, it's left side of the roof of CS as well before you make a decision.
We did that.
You did transeptal.
Yeah.
So you have a tracing from there.
Yeah.
Okay.
But it's late than the CS910.
Huh? What do you mean?
I mean the signal from the roof of the CS.
No. I'm talking
from the left side
transeptal
is,
this patient.
yeah.
You did the transeptal.
Yeah.
And then map the left side.
Yeah.
Left septum.
Left septum.
What's displayed where?
I didn't record that because yesterday.
Anyway, if you can get the tracing for us and you make a clear notation, and let's review this, okay?
Okay, I will take it off and send it to you again.
Yeah. And then I can make a comment for send it back to you.
Okay.
All right.
And I have some more tracing. So this
Yes.
is
Okay.
before the ablation section full site. The same, also roof of the CSOs.
Right.
And the signal is early, around 17 milliseconds.
Yeah, but the reason I'm asking, Chad, is important here to look at the signal, okay? First component of your early signal, even the RS, is a far field, not a near field. That's what I was asking about that. Your near field signal, local signal actually recording is right behind the high notched frequency signal. So this tall R wave that you see sometimes become Q as well, QR, is the initial component of far field compared to your CS signal. Take a look at how sharp it is.
Yeah.
So that's why I think we really need to look at both sides before you can decide to burn. Okay.
Dr. Wang and Dr. Han, it is already 8:15 and
okay.
Behind the schedule. So after review all the ECG tracing,
right.
Let's have another chance to review
all
the
right.
case.
That'd be great. Good idea. Okay.
Thank you very much.
Thanks, Sohan. Good job.
Thank you very much. Thank you, Dr. Han. Okay. EJ